The views expressed on Science for the People are not necessarily the views of this station, its affiliates, sponsors, or advertisers.
This week on Science for the People, we're talking about our changing understanding of post-traumatic stress disorder and how we define the trauma that can trigger it. Welcome to Science for the People. I'm Rochelle Saunders. With me is Alexei Morozov, an assistant professor at the Virginia Tech Carilion Research Institute. He and his lab are interested in neuronal substrates responsible for transmission of social signals of distress and use mouse models to help determine how these circuits become altered in pathological conditions, including post-traumatic stress disorder. Alexei, welcome to Science for the People.
Great to hear from you. Good morning.
So before we get started talking about the specific study here, can you maybe give us a little introduction to what you and your lab do and what interests you?
So we are interested in how psychological trauma causes post-traumatic stress disorder. And our specific interest in psychological trauma is that many previous studies focus on physical trauma, where people experience real physical pain and physical distress and then develop Ptsd. But in reality, in our regular life, we very often encounter a psychological trauma where there is no physical pain or no physical distress. And such models are much more rare, and we are trying to model it in animal studies, where we take a mouse and we expose a mouse to another mouse which is receiving electrical foot shock. So our subjects do not experience any physical pain or any physical distress, but they undergo some changes in their brain, and we study how those changes happen and what those changes are.
So you guys are specifically interested in what happens when we witness pain or trauma from somebody else and how that affects us as a witness.
Exactly. That's our exact model, but the interpretation of this model and any results coming from it can be further applied to situations when we learn, for example, about our relatives being sick, or watch our friends die, or watch our friends being hurt. So all those situations where we know that something bad is happening to somebody else, not necessarily to us. And that's where we want to understand how our brain responds and changes.
So you guys specifically focus on mouse models, and I'm curious, why use mouse models for something like this?
So such studies really cannot be done in humans because we cannot subject humans to pain and suffering. We can do such experiments in animals, of course, with certain restrictions, and we get all various approvals from animal care committees which make sure that we don't do too much bad to the animals. But basically, we have many limitations to work in humans. Also, in human, we cannot invade into the brain. We cannot cut brain open, and we cannot take measures from the brain same way as we can do in the animals.
So in a lot of ways, a mouse model really allows you to go a lot farther with the research and be a lot more specific, I guess?
Exactly, yeah. And in a mouse model, we can ask very specific questions. For example, we can ask how a particular type of cells in the brain do their job. For example, we can introduce genetic mutations in the mouse which allow us to specifically visualize or monitor activity or manipulate activity of specific parts of the brain. Of course, we cannot manipulate human brain like this because we cannot invade, put viruses, put genetic mutations in the human brain. It's simply prohibited by any rules of human society.
So how similar are mouse brains and human brains? I mean, what makes them good models?
Unfortunately, they are still quite different, but there are so many things in common. For example, the center of the brain, which is responsible for fear, which is called the amygdala, is almost identical between human and mice, because this is a very ancient structure, and it is responsible for helps our survival because it protects us from many danger. So that's why it's a very common among many organisms. And interestingly, many psychiatric disorders involve disruption of our perception of fear and our learning of fear and our fear memories. That's why we are focusing on parts of the brain which are very similar between those very far related organisms.
So what about the limitations of mouse models? Obviously, the brain of a mouse is very different from the brain of a human being. So we can only take the conclusions from a study on a mouse model so far, right?
Exactly. We can only have limited interpretation of our findings. We cannot measure many things which we can measure in human's brain. And of course, human behavior is much more rich and sophisticated than behavior of any animal. Therefore, we cannot really study behaviors which are very specific to a human. We have to focus on behavior which are shared between those species. But once we study those common behaviors, or we can call them behavioral traits, we can find commonalities which inform us about what is happening in the human brain.
So after studies like yours on mouse models, I mean, what's the next step? Is it usually more research on mice? Is it research on a different animal, maybe chimps or apes? I mean, is it studies with humans to try and figure out if what we're seeing in mice is relevant to how human brains work? Because I can see how it's easy to look at studies on mice in isolation and kind of think, well, it's on mice. It doesn't really tell us anything. But the power of science is in a lot of these kind of small steps that add up to create new understanding. So if this study and studies like it are kind of a step or a branch, then what do the next steps or branches look like?
Okay, so the next steps usually is taking, if we want to, let's talk about next steps in two ways. One kind of next steps is to further understand how mouse brain works. So in other words, once we learn something from our current experiments, we can always go a step further. For example, we learn about certain group of neurons in the brain. Then we will ask next question, what about neurons that connect to those neurons, and so forth. So we can slowly move along brain connections in the mouse brain and understand more and more what is happening there. And this is most likely what my laboratory is going to do. But there is also another path, so-called path of translation, when we translate our knowledge that we obtain in the mouse brain to the human studies. And there are a couple other branches here. One is a technical branch. When we study mouse brain, we try to manipulate it, or we try to take certain measures from it. And while we are doing it, we are developing techniques which allow us to take such measures. For example, we can record from the brain and record certain potentials, for example, electrical fields, how they change. And once we learn from a mouse that certain condition, for example, psychological trauma, changes, for example, oscillations in the brain, then we can make a prediction that perhaps such oscillations have something to do with function of human brain also. And taking this knowledge, we can, researchers who study on humans, they can take this knowledge and they can connect electrodes to the skull, and they can measure activity of human brain under conditions which would mimic our experimental conditions. So in other words, we provide the knowledge to apply to future human studies which someone else will take. So that's how it could be translated about methodology. And second, if we learn basic functions, say if we identify part of the brain which, say, was activated by psychological trauma or suppressed by psychological trauma, then human researchers who do MRI imaging of a human brain, they can focus on that particular area, and then they can apply their own models to study how this area behaves in their system. So in other words, it's just a flow of information which help people working at a different level. Say if we provide new information, the people who work on humans, they can take it and try applying it in their model.
So would it be fair to say that one of the things that good research on mouse models does is allow us to ask better questions about the human brain and also give us a better idea of how to create better experiments for research on human brains?
Exactly. Both are correct. Both suggestions are quite correct. So first, we can ask new questions about function of a human brain. For example, if we found a change in certain neurochemicals in the mouse brain, we can ask, are those neurochemicals also changing in the human brain in the same conditions? And there are methods to measure neurochemicals without invading into the brain, for example, by imaging techniques, by PET imaging techniques. So those can be directly translated. And the second is, as I'm now a little bit repeating what I already said, the methodologies that we develop in mice. We cannot initially develop it using human brain, but once we know, for example, that certain type of oscillatory activity can be measured or certain type of stimulation of the brain can cause some changes, Those can be applied in humans because in humans also there are techniques like deep brain stimulation or transcranial magnetic stimulation where researchers are trying to modify brain activity by external stimuli, and those can be information for those studies can be taken from the mouse or rodent experiments.
Okay, so let's look at one specific study that your lab put out recently, which looked at how mice are influenced by witnessing other mice go through stressful experiences. Could you maybe start by giving us just the abstract or the kind of elevator pitch of what this study was about?
Okay, so we have actually two published studies. One study was published about a year ago, and another one was very recent. So to understand our recent study, it is necessary to say a few words about the very first one. So in the very first study, we found that if an animal is exposed to a partner, a sibling, who is receiving electrical foot shocks, then later on, this particular mouse, the witness of somebody being shocked, will acquire new property. So he will be able to learn aversive experience much better than before. So specifically what happens is we let him watch the partner being shocked, and on the next day we put him through a procedure which is called inhibitory avoidance or passive avoidance training. In that procedure, animal has to learn that he should not go to a place where he will be otherwise receiving electrical foot shock and himself. And what we found that animal who watched somebody being shocked previously, he learns that second task much better than the animal who did not have observing experience. So then our next question was, what happened in the brain to explain such changes? And that's where our second study came up. And in the second study, we were looking in the area of the brain which is called the prefrontal cortex. This is the area which is responsible for making decisions. And the prefrontal cortex is responsible for making decisions both in humans and mice, pretty much in every vertebrate animal. And we asked a simple question, are there any changes in how neuronal signals are received by the prefrontal cortex after animal had an experience of watching somebody being shocked? And signals which arrive in prefrontal cortex are usually controlled by so-called inhibitory interneurons. In the brain, there are two major types of neurons, excitatory neurons and inhibitory neurons. So excitatory neurons transmit information from one place to the next, primitively speaking. But inhibitory neurons, they work as a gate. They will prevent or suppress or slow down transmission of excitatory signals. And there is a balance. And there are different types of interneurons. Some interneurons control flow of information at certain places in the brain. Other interneurons control flow of information elsewhere. And what we found in the study, that the two types of interneurons which control flow of information in different layers of the prefrontal cortex undergo opposing changes. So we found that a group of interneurons which are called parvalbumin positive interneurons become less active after animal observed fear, whereas another group of interneurons, which are called somatostatin interneurons, they become more active. And interestingly, the somatostatin interneurons control flow of information in the upper layer of the prefrontal cortex. That's the place where information from sensory areas of cortex comes. So it's more like sensory information or higher order processed information about all sorts of modalities. Whereas the parvalbumin positive interneurons control flow of information from deeper layers of the brain, like the amygdala, which is the fear center of the brain. So that information has influence on prefrontal cortex from the side of our basic instincts, like fear, for example. Mm-hmm. And what our study showed is that by shifting this balance, potentially we are shifting flow of sensory high-order information versus flow of information about fear by giving preference to the information about fear. So it might be a very long explanation, but if we take it further to human studies, there's an implication which the immediate question which come up, is it going to change connectivity between prefrontal cortex and area which control fear versus prefrontal cortex and area which provide us higher order sensory information?
So let me
predict that it will.
So let me make sure that I understand.
Okay.
So I think what you're saying, and obviously this is going to be vastly simplified, but let me find out if the gist is correct here, is that what you found is that there's something in the brain that changes that makes it easier or more preferential for those kind of instinctual fear feelings to get through and sort of control us than the sort of higher order, I guess, quote unquote, rational, cognitive, that kind of information to sort of control us or for us to be controlled.
Your understanding is pretty good, pretty accurate. Yes.
Okay.
So, and you can look at the prefrontal cortex as a judge, as a decision maker who is weighing what kind of decision is correct based on what kind of information the judge is receiving. And imagine somebody is telling him, oh, we are in danger, we have to run away, we have to stop thinking, we have to immediately take action to escape or something else. That's the information about fear. And then somebody else is telling him, okay, let's think, we just learned that 2 times 2 equals 4, and maybe something else, and maybe we heard some music somewhere, and maybe somebody told me something. So this is more sophisticated information, and maybe we know about certain events, something should happen, let's calculate it, let's think about it. And so the balance between these two flows of information, I'm making it very primitive, I'm probably simplifying it too much, but that's the way to understand it better. So that judge has to make a decision. And if there was a prior experience of animal being shocked, that decision will become more biased towards flow of information about the fear.
Okay, so it becomes more biased towards that kind of instinctual basis.
Exactly, but more biased towards basic instincts.
So there was another study that came out just a few days ago, and if you haven't heard of it, feel free to just say so. But the study looked at using ketamine in mice as sort of a vaccine of some kind to try and prevent some PTSD-like symptoms. Have you heard of that study? I think it just came out a few days ago.
Yes. Actually, I didn't mention that, but in our initial studies about psychological trauma, the first study where there is a behavioral effect of watching fear, we also used ketamine in that study, and we showed that if we injected ketamine immediately after animal observed another mouse being shocked, the effect of that observation is gone. So ketamine prevents effect of observational fear on subsequent fear learning. So that's why effects of ketamine are not surprising. Ketamine is known for probably last 15 years as a rapidly acting antidepressant, and it's also known as a strong modulator of neuronal function. It causes actually neuronal growth. Studies by Ronald Duman Laboratory at Yale University show that injecting very low dose of ketamine promotes neurogenesis, and that effect is an opposing effect to adverse effects of stress. So that's why, yes, effects of ketamine are not surprising, and it's worthwhile to study how ketamine works.
So I guess the idea there is potentially, if this turns out to be a good solution for people who we know are going into potentially high-risk situations, so combat zones, that kind of thing, that we might be able to preemptively assist them by giving them some kind of ketamine-like vaccine to try and prevent some of these PTSD symptoms from setting in.
I would rather think about it as administering ketamine immediately after person had a very bad aversive experience. I would not give ketamine prior to people going into the battlefield. Mm-hmm. But at least based on our study, I would say if person witnessed his friends die or been hurt or participate in very stressful battle, it would be okay to give maybe a little bit of ketamine at the end of the day. And maybe those bad memories or bad changes in the brain, maybe they would be wiped off or they would not develop. Because what is known about ketamine increases brain activity and causes certain pattern of oscillations in the brain. And this could be considered like a massage therapy for the brain, where you wipe off or clean off certain changes or certain processes which otherwise would develop into something really bad. So that's how I view the ketamine effects.
Alexei, thank you so much. The research is really fascinating, and I'm definitely going to keep an eye on it. It's been interesting looking into this.
It was really fun talking with you and your audience.
And if you want to learn more about Alexei Morozov or his research, you can find links to get you started in the show notes for this episode, which, as always, you can find on our website at scienceforthepeople.ca.
Science for the People is a weekly radio show and podcast that explores everyday life from a scientific perspective. We are a member of the Skeptic Network, a collection of blogs, podcasts, and video content focusing on science and critical thinking. To find out where Science for the People airs near you, or to listen to past episodes, check out our website at scienceforthepeople.ca. You'll also find links to support us at Patreon, to connect with us on Facebook and Twitter, and to subscribe to the podcast in iTunes. And now, back to the show.
You're listening to Science for the People. I'm your host, Rochelle Saunders. With me is psychologist Dr. Monica Williams, the director of the Behavioral Wellness Clinic in Louisville, Kentucky. She's an associate professor at the University of Connecticut and director in the Lab for Culture and Mental Health Disparities. She's a board-certified cognitive behavioral specialist and a licensed psychologist in 2 states. Monica, welcome to Science for the People.
Thank you. It's great to be here.
So probably the first place we should start is the definition of PTSD. So in the DSM-5, what is the definition that we get?
Right. So PTSD is basically considered a reaction to a very frightening experience that we define as a trauma, usually involving, a threat to somebody's life or well-being. And it's typically been defined as something that happens when when we're so frightened that we don't know how to cope with it. And it can involve a lot of different kinds of symptoms. And sometimes because of the many different symptoms that are attached to PTSD, it can be hard to diagnose because it can include not just things like flashbacks, but also depression, anxiety, social phobia, psychosis, dissociation, and all of those things can be their own disorder. So PTSD can be very disabling because of the severe and varied symptoms. And as I pointed out, hard sometimes to diagnose.
So what do we mean when we say trauma in this context? There's a specific definition of trauma we work with when we talk about PTSD, correct?
Correct. So traditionally, in terms of the DSM, we've conceptualized trauma as a discrete event. But in actuality, what we're finding is that trauma tends to be cumulative. So actually most people who experience a trauma do not go on to have PTSD. Usually they recover on their own. And what research has found is that it's really often the third trauma that somebody has or the fourth trauma that they have that pushes them over into being traumatized in the way we think of PTSD. And so we're really starting to better understand that trauma is often about many experiences over a lifetime that have ultimately exhausted a person's ability to cope with them.
Yeah, I sort of was assuming that experiencing some form of PTSD-like symptoms immediately after a trauma is pretty common. For instance, after being in a car accident, it seems likely it would be common for the first few times back behind the wheel of a car for someone to feel a lot more anxious about that. What differentiates some of the sort of normal ways we process and react after a trauma from kind of a PTSD or something that becomes really problematic?
Right. That's a really good example because it is very common for people who've had a trauma to temporarily have some PTSD-like symptoms. And so we actually have another diagnosis that we use to describe this early constellation of symptoms so that it isn't confused with PTSD. It's like acute stress disorder. So that's very common. I was, in a car accident once. I remember very clearly feeling jumpy and anxious getting back behind the wheel. But most of us in these situations, we do eventually get back behind the wheel and we essentially face our fear and then eventually the fear goes away. And so that's part of that natural recovery process. Another part of that natural recovery process is talking to people about our experience, processing it, making sense out of it, getting encouragement and support from people who are important to us. All of these things help us recover naturally from a trauma. So that's why most people don't go on to have PTSD because they employ those different strategies to get better.
So when we're talking about PTSD, is it that different? Is it something that happens that stops us from kind of processing it in this normal way?
Yes. So what we find with PTSD is that people who are traumatized have not been able to engage in this process of natural healing for one reason or another. And one of the biggest obstacles to recovery that I see is this sense of shame that has prevented them from being able to talk to other people, get support, and make meaning out of the experience. So when you look at the different types of things that traumatize people, sexual assault is near the top, whereas things like natural disasters and car accidents are near the bottom. And that's because in large part that when people are in car accidents or experience natural disasters, they're able to talk to other people about them without that same sense of shame and stigma that may be accompanied with something like a sexual assault.
So I've also heard the term complex trauma before. What does that mean? Is that something different?
No, actually, it's very similar. I mean, it's basically a way of explaining a situation where a person has had ongoing trauma for a long period of time, and the fallout from that happens, in terms of a person's life course and personality and just a lot of different facets of the person's life that are going to be touched by being traumatized for a long time on an ongoing basis. And you often see this with people who maybe have been victims of childhood abuse. Often that's not a one-time thing. That could something, if it's happening from a neighbor or relative, that can happen over a long period of time. So
I guess other forms of domestic abuse would fall into this as well, probably.
Certainly it could.
I'm curious. The word trauma is used a lot these days to describe a lot of things, kind of like the word depression or anxiety. I mean, how do we partition out the use of these words in kind of everyday vernacular from the occurrence of these in a clinical sense? What's the difference?
Sure. So you're absolutely right. People may use the term trauma colloquially to just refer to something really bad or stressful that happened to them. But what is different about having a diagnosis of PTSD and being traumatized in that sense is that there's a very specific constellation of symptoms that we're looking for in several different categories. And so PTSD will include, what we might term as avoidance symptoms. So that could be things like avoiding things that remind you of the trauma, avoiding places that remind a person of the trauma, trying to avoid memories or thoughts about the trauma. Other symptoms are things that we might term as hyperarousal. So that means being exceptionally vigilant for danger. And so that could manifest as being very jumpy. So if someone taps you from behind, you jump out of your skin, or not being able to sleep because you're constantly on alert for danger. And so there are these sort of specific symptoms that we're looking for when we make a diagnosis. And so it's usually fairly clear if somebody has these symptoms, and we can make a diagnosis.
So when you're looking to diagnose PTSD, are you looking for a number of these symptoms to be manifesting all together, or is it a situation of just one or two can indicate PTSD is present?
Generally, you have to have symptoms in each category. So you'd have to have some avoidance, hyperarousal. You'd have to have some symptoms of re-experiencing the trauma, and these could be flashbacks, but they could also be things like bad dreams or intrusive thoughts. And then now one category we also are looking at is, what we might think of as negative thoughts. For example, distorted ideas about the world, like, the world will never be a safe place for me, or negative thoughts about a person as a result of the trauma, like, I can't do anything right and I can't cope with stressful situations. So we're looking for symptoms in all of those areas to make a diagnosis.
So do we know what happens in the brain of someone with PTSD? Say if we put someone in an MRI or something like that, would we be able to see differences in the brain? Is this like a physical thing that happens?
There absolutely are differences in the brains of people who've had trauma. And in fact, there's a lot of exciting and new research that people are doing looking at these things. The issue is it's not necessarily clear how helpful this knowledge is because, we know that PTSD is happening in the brain because, everything happens in the brain. So
that's true.
So it's not necessarily clear that if we know what areas of the brain are affected, that we could go in and fix them. We're pretty far from being able to do that.
Is this helpful, knowing that it's a physical change, to reduce the amount of stigma that people might feel if they know it's something that's physically happening in their brain versus just feeling like they can't cope and they should be able to?
Oh, absolutely. I think it can definitely be helpful for that. Just like if you break your leg, you can go to the emergency room and they'll take an x-ray and they'll show you your broken leg. And that, gives you a little bit of confirmation as to why you feel so badly. Likewise, I think it could be very helpful to know that, that there are some, visible markers of trauma that we can detect in the brain.
So what's the range of PTSD severity? I assume that there's a wide range of how PTSD can impact and manifest in somebody's life.
Yes, there are a lot of different ways. As I was mentioning before, for example, somebody who's been traumatized, if they've been held up at gunpoint, they might be afraid to leave their home because they might, run into somebody else who might do the same. Whereas if somebody was traumatized in the workplace, they may be fearful of going to work. So it could differ in that way.
So are the different symptoms of PTSD more likely to manifest from different types of traumas? I'm thinking, for example, are the symptoms of a young woman with PTSD who has experienced sexual assault likely to be very different set than those seen in a war vet who has PTSD from participating in combat?
Well, I think, the basic symptom categories are going to be the same, but the specifics of the symptoms are going to differ. So someone who's been subjected to a sexual assault, the young woman may be afraid of just being around young males because that reminds her of her attacker. Whereas somebody who's been in combat, they may be vigilant for things like garbage on the side of the road that they worry could be a bomb. So the specific content of the fears can be very different, but yet both people may have trouble sleeping, but one may have nightmares about being attacked and the other might have nightmares about being in Iraq.
So there is definitely some work that has to be done about looking at the exact symptoms that are causing problems in someone's life and trying to figure out which categories those fall into, I guess.
Yeah, I would say so, but it's generally not too difficult to divide up the symptoms into the necessary categories, if you have some experience working with people who are traumatized.
So I do want to talk about this idea that we mentioned before about PTSD being something that happens after a trauma. And we usually think of that as something like an event, a single event that has happened in our lives. But you talked a little bit about how we're seeing this is not necessarily the case, as a series of things can kind of tip us over into feeling or experiencing a trauma. And in particular, you've talked before in articles and interviews about how racism and systematic racism can really cause PTSD in a way that I think most people find a little unfamiliar from the definitions we've seen of PTSD in the past. So can you unpack that a little bit for us?
Sure. So traditionally, we've thought of a traumatizing event as something that's life-threatening, whereas, my experience has been that racism can be a cause of PTSD. So, people don't typically think of racism as something that's life-threatening unless, you've got people threatening you or burning crosses on your lawn, running around in white sheets. Obviously, something like that could potentially be traumatizing, but of course, we don't see a whole lot of that anymore. Most racism tends to be more subtle. And so people sometimes have a hard time understanding how racism can be traumatizing. And so what I like to do is sort of go back to the idea, again, that it's not usually one thing that traumatizes a person. It can be a lifetime of bad experiences that, and eventually you have the straw that breaks the camel's back and the person becomes traumatized, and it could be a big thing that triggers it or a small thing, but it's sort of the accumulation of experiences that leads to being traumatized. And so for example, and people find it easier to understand if I give examples of other sorts of things that are more clearly traumatizing. For example, sexual harassment. If a person is subject to sexual harassment on the job, it's not usually one sexual remark that traumatizes them, but it's having to deal with this for months or even years. that can be traumatizing. And in the same way, you may see things like kids who get bullied becoming traumatized. And usually, again, it isn't because they were bullied once or teased once. That happens to most kids, but rather that they're bullied and teased a lot over a period of time, that it gets to the point where they can't cope anymore.
When thinking about an idea like race-based discrimination causing trauma, I mean, how do we differentiate or draw a line, and probably a fuzzy line, between an increased amount of anxiety, even a clinical problematic type of anxiety, and PTSD specifically? Or is there a lot of crossover there?
Well, I think that experiencing racism could actually result in different kinds of psychopathology. But I have certainly seen very clear PTSD symptoms resulting from racism. And again, we're looking for those symptoms in those 4 categories. And, and when somebody's having strong symptoms in all categories and they're disabled, I'm not going to say, no, you weren't traumatized because what happened to you doesn't fit the definition that's in this big Eurocentric book about psychopathology. I'm going to say, no, you're traumatized. Let's figure out how that happened.
It's interesting that you bring that up, because I wanted to talk a little bit about the historical context of the definitions and diagnoses in the DSM-5. As you say, it comes from a background of mostly white, mostly Eurocentric people doing scientific work and doing clinical work with quite often a mostly white, mostly European-based set of people. So I'm assuming that this is somewhat pervasive in the DSM-5, because it seems like the idea that something like PTSD being caused or can be caused by racial discrimination is something that's pretty new into our idea set for this.
Right. Yeah. So, the thing to remember is that most of our conceptualizations of mental illness are sort of based on these Western models that were developed from observing mostly white people and mostly mental health practitioners who are also white, and they bring with them their cultural perspective on those disorders. And so everyone likes to think and hope that these are universals, but in fact, many aspects of psychopathology are cultural, and so it's really important that we consider that when we're looking at psychopathology. And a lot of these cultural concepts have not yet worked their way into the DSM. And, there's a little appendix in the back, called Cultural Concepts of Distress. But these illnesses in this little tiny section actually afflict a large number of people worldwide. And because we don't understand them or don't see them, or we don't see them in the same way, in our American or European samples, it's easy to ignore them and think they don't exist. So on that note, there are many facets of mental illness and psychopathology that we don't necessarily fully appreciate because we're looking through this Eurocentric lens.
I can see how that lens would be problematic with patients and clinicians, especially if someone is Black and is feeling traumatized by some of the discrimination and racism that they experience in their everyday life, trying to talk and express these feelings to their white therapist. I can see how that could cause a lot of problems. There's a big cultural gap there, and it potentially could be very large depending on the cultural experience and biases of the clinician as well.
Absolutely. So it's going to be very important that someone who's traumatized be able to process their experiences in a safe environment. And so somebody who's been traumatized as a result of racism, if they go to a therapist and want to talk about what they experienced, it's going to be difficult if the therapist doesn't even really understand or believe in racism. In fact, I saw a poll recently that showed that most white Americans, that slightly over half, believe that racism against white people is just as big of a problem as racism against Black people, which is absolutely absurd. So, if you have a therapist who is thinking that, it's going to be hard for them to appreciate or empathize what their racially traumatized client is going through.
So, is that starting to change? Are we starting to take the experiences of a wider diversity of people into account as we're creating the next version of the DSM? I assume the DSM-6 will come at some point in the future?
Well, the DSM is built largely around the research base. And so in order to, justify changes in it, we have to have research behind sort of the things that we're wanting to advance. And unfortunately, ethnic minority research is lagging far behind other areas of inquiry. Now, we do have some research in the last 15 to 20 years that shows a lot of very negative mental health consequences as a result of racism and discrimination. But that body of work is relatively new compared to other areas. And so I think that I'm hoping that by the time DSM-6 rolls around, we do have enough research that the other folks who are putting it together are going to think, okay, this is credible enough that we need to include it. But it's incumbent on people like me to do the research so that we can make a strong case for it.
Within the scientific community and the clinical community, is there pushback to the idea that something like systematic racism can cause trauma that would then prompt something like PTSD? Is that a controversial idea in the communities now, or is it pretty much accepted, or are people open to that idea?
I think people are open to that idea, particularly people who study trauma. That being said, I have run into a number of other people in mental health who were confused by the idea. Not so many people said, "Oh, that's impossible," but definitely some confusion, I'll say.
So you mentioned that some people are more or less likely to develop PTSD after trauma. Are there known risk factors for PTSD?
Sure, there are a number of known risk factors. And certainly one of the things we see is that interpersonal types of traumatization are more likely, again, to cause PTSD. And then also, as I said before, the more traumas you've had in the past, the more likely you are to have it. We do know that different ethnic minority groups are at higher risk of PTSD than white Americans, and again, that's one of those one of those differences that I think can be explained at least in part by racism, although there are other explanations as well. And then on top of, traumatic events, I think it's also important to consider the role of things like historical trauma and cultural trauma and community trauma, as these also contribute to the overall level of traumatization that's experienced by an individual. And so, those are some facets that people haven't really paid a lot of attention to in the past that now a lot of researchers are saying, hey, we have to consider this as well.
When you mentioned earlier in that interrelational trauma, can you define that? I'm not sure I know exactly what that means.
Right. That just means trauma involving other people, like, being traumatized, like, for example, being domestic violence, where you may be traumatized by a significant other, or something like assault from another person or rape. Traumas involving other people, and racism is a kind of trauma that almost always involves other people. So again, that makes that type of trauma particularly, particularly concerning as a way of becoming traumatized. And another thing is when someone experiences racism, they're often embarrassed by it. They often feel ashamed about it. They don't want to go around and tell everyone, hey, I've been discriminated against. Contrary to what people might believe, most people who experience these things don't really want to talk about it because it's painful and embarrassing, and they may tell other people even in their own ethnic group, and people may say, well, hey, I experienced that too. You just got to suck it up. Or they may talk to people outside their ethnic group who don't understand or don't believe it. And so that might contribute to them feeling like there's no place where they can go and get support for what happened to them.
Which is, I think, one of the most difficult parts about combating racism or dealing with it on a personal level is the shame that gets associated with it, even though there really shouldn't be any shame about being treated in a way that is not cool.
Right. Exactly. It's just like, the shame someone might feel from having been raped. It's like, it's not the victim's fault that they were raped, but as soon as someone says that, immediately people are judging and they're looking for reasons, and they're saying, well, you shouldn't have been out late, or you shouldn't have worn a skirt that was that short, or you shouldn't have, gone with that guy to the bar. And, and it's so unfair to, place all the blame on the person who was victimized rather than looking at the real source of it, which is the perpetrator.
So for someone who's diagnosed with PTSD, what's the treatment protocol? What's the first step?
Right. Well, there's one of the nice things about PTSD is actually there are a number of effective treatments for it. The first step would be to get a good assessment and diagnosis by somebody who specializes in PTSD. And then I would recommend an evidence-based treatment for it. And so the most effective treatments for PTSD have a large exposure component to them, which means that that people are confronting the things that they're afraid of. And generally research shows that PTSD is very treatable with very high success rates if people stay in treatment. And that tends to be the tricky thing is that these exposure-based treatments can be very aversive, and people often drop out of treatment and don't get better.
So what types of treatments are evidence-based for PTSD?
Well, one type of treatment that has one of the largest bases of evidence behind it is prolonged exposure. That was a treatment developed by Dr. Edna Foa and colleagues at the University of Pennsylvania. Other kinds of empirically supported treatments include cognitive processing therapy, which has a lot of very similar techniques to prolonged exposure. Then there are some other treatments like EMDR, which has some evidence behind it, although it's a bit controversial and isn't clear that it's as effective as the other two treatments that I mentioned. And then sometimes people also take medication, which generally is not a cure for PTSD, but can help relieve some of the symptoms.
So the drug protocols would be to help people kind of deal with some of the immediate symptoms so that they can more effectively kind of go through the therapy process.
Right. That would be the ideal use of medication.
I'm curious, because you use the word evidence-based, that also implies that there are some non-evidence-based treatments out there. Would you care to talk about any of those or list any of them for people who might be looking to get treatment for their PTSD and trying to sort out what's evidence-based and what's not?
Sure. I mean, things like relaxation techniques, that's not really been shown to necessarily be helpful. Also, therapy that doesn't involve talking about your trauma, that's not going to help too much. And then there's sort of some therapies that are in between that may or may not be helpful. I mean, supportive therapy and some general counseling can be helpful if it includes, really talking about the trauma in a way that is helping the person process it, think about it differently. That's going to be helpful. But if it's just, saying, hey, I had this trauma happen to me, and maybe coping with some of the fallout of that trauma in the person's life, it's probably not going to be very helpful in terms of, reducing their PTSD symptoms in the long run.
I know some people who are really resistant to the idea of talk therapy. So can you talk a little bit about talk therapy, what it can do and what evidence exists to support its use and why talk therapy is so important?
Well, it's kind of hard because when people use say talk therapy, that could mean a couple different things. So we'll have to clarify what you mean, because some people use the term talk therapy to talk about any kind of psychotherapy that involves talking, and then sometimes that refers to really more the supportive counseling kind of therapy. So
I guess then the question that I should ask is, why is talking about a trauma so important to getting past it?
Okay, yes, I can answer that question. So talking about it is really important because it's one way of, number one, facing your fear. Oftentimes people who've been traumatized are afraid that if they think about it or talk about it, they're going to fall apart and not be able to cope. And so what talking about it shows them is that, yes, they can talk about it and they can think about it, and they're going to feel a little bad in the short term, but they're going to be okay. And so it kind of helps disconfirm that fear that talking about it and thinking about it is just as bad as the actual trauma, because talking and thinking about it is a completely safe activity. The trauma was dangerous, but recounting it is not. And so it's really important that people learn that distinction who have been traumatized. And the other thing that talking can do is it can help the person think about the trauma differently. So often when people who've been traumatized are thinking about the fact that they've been traumatized, they're often beating themselves up, ruminating on things that they imagine they did wrong or why it was their fault. And often getting a new perspective on the trauma can really help them see that all these things they're beating themselves up over actually didn't happen. That they actually did their best in a really scary situation, and learning to appreciate that can go a very long way toward recovery. And then also finally this piece involving shame, where the person feels defective because either they allowed themselves to be traumatized or they were the victims of trauma. Having another supportive person like a therapist be able to reflect back to them that, there's nothing shameful about what they went through. And in fact, being able to reframe that in terms of the person's bravery and ability to survive a difficult situation. All of those things can really help shift the perspective to help move them out of that place of shame and self-blame to a place where they feel empowered after treatment.
I want to talk a little bit about sexual trauma and how that manifests, because I think there's a lot of myths in our culture about what a victim of sexual trauma acts like, or what they're supposed to act like. So can you unpack that a little? Because I feel like, especially in a world where there are sexual assaults or rapes trying to be prosecuted that get a lot of high profile media coverage, we get this bounce back of people saying, well, clearly they're lying because someone who really experienced sexual assault wouldn't do this or wouldn't do that.
Yeah, I hate it when people say things like that, because you know what? Nobody knows what they are going to do when they are traumatized. Somebody who says that they could be raped tomorrow and not at all react like they thought they were going to react. It's awful to be traumatized, and people who experience sexual assault, some of them are going to react in a way that sort of fits with our schema of how people who are raped are supposed to act. They maybe cry, upset, call the police, file charges, get support from their girlfriends, go to the hospital and do the rape kit thing. And if they do that, that's one very, acceptable way of responding. But some people are going to be so shocked, they're not going to tell anybody. They may clam up and be numb and withdraw. And then frankly, what we know about what happens when people who rape are reported, most of those people, are not convicted. They don't spend any time in jail. And in fact, it ends up being much more stressful for the victim, who has to go to court and recount her story to a potentially hostile audience, an attorney who's going to pick it apart and find a way to turn it all on her and blame her for what happened. It makes a lot of sense. A lot of times victims say, you know what, I don't want to go through that. I can't go through that. It's too much for me. And so then, people might assume, well, she didn't file charges or she didn't report it to the police. Therefore, she must have wanted it. That's completely absurd.
There was a fairly famous and very well publicized case in Canada where a public figure was accused of sexual assault, several sexual assaults. And one of the defenses was that to one of the women, well, you continued to correspond with this person over Facebook. And that kind of defense was used as well, clearly you weren't that traumatized, or clearly it wasn't that bad, or it wasn't assault. If you were still able to interact with this person, if you were willing to send them a Facebook message afterwards, where does that sit in kind of the normalcy of response to something like a sexual assault?
Not abnormal at all. If somebody that you cared about and trusted assaults you, it may take you a little while to figure out what just happened, because there's like a huge conflict in your head, right? This is somebody that maybe you trusted or you cared about, and they did something that was really hurtful and betrayed you. And it can be very hard to reconcile those two things. And the fact of the matter is, most people are not all good or all bad. They're somewhere in between. And for some reason, we think that we, have to make a decision and that someone's all good or all bad. But trying to deal with that conflict can sometimes take time. And, like I said, particularly if that person who did that assault is someone who's known to you. I mean, often we see this with children. They're sexually abused or physically abused by a parent, but they love that parent. And so, because that's what they know. And so they may not want that parent to be punished or go to jail, because, they have these conflicting and confusing feelings.
And I would expect as well, if there's a situation where this is maybe you've been assaulted by someone that you work with, or that has the ability to influence your career in major ways, that you would have a personal motivation to either keep that quiet or to continue to interact with that person in at least a civil manner, in order to make sure that you don't get fired, to make sure that your career has the best head start, and that those would all be sort of considerations around the power in the situation as well, which would cause you to maybe act in certain ways that you might not if it was a stranger, or you might not if it was just a friend.
Oh yeah, absolutely. If something like this happens to somebody and it's in a situation where the other person has power over you, you have to really think carefully and strategically about what your next steps are going to be, because that person can retaliate against you, and that might cost you your job, and your reputation and your social network. There could be a lot of very bad consequences, and so that's often a very unfortunate and awful place that a lot of women get stuck in when somebody over them does something horrible like this. And usually the sad fact is that those people in those powerful positions are often not punished for what they've done. And so it's really a losing game for the person who's been victimized to draw attention to the problem, because again, in most circumstances, the victim is going to be punished. Everybody in the workplace is going to turn on the victim for blowing the whistle. And that person it may be further traumatized by the fallout of that.
Yeah, there's definitely, if there's a large public fallout, that often includes a lot of shaming practices, which I can see would just feed into that already existing shame that's probably there and cause a lot of extra problems. So I can see how someone would completely validly want to avoid that.
Yeah.
So just one last question before we sign off. I'm curious, what are the major kind of underlying questions about PTSD and how we deal with or recover from trauma happening in the scientific and clinical discourse today? Kind of what are the biggest open questions that people are investigating?
Right. Well, I think one of the biggest questions is, most people who do stay in treatment get better, but there's some who don't. How do we help those people who don't get better, even though they may do their best with these empirically supported treatments? I think that's one question. Another question is, how do we engage people in treatment who are so afraid of the traumatic thoughts and memories that they won't even come to therapy, or they come once and then they don't come back? I would say most of the people who call my clinic with PTSD, they call, and half of them don't show up for their first appointment. And then the half who do show up for their first appointment don't show up for their second appointment.
Oh, wow.
So it's very hard to get people engaged in treatment. And I always think, I wish you knew how effective this could be and how wonderful you'll feel afterwards. But it's hard treatment, and it's, it can be agonizing on the front end to confront those really scary thoughts that the person has been avoiding sometimes for years and years. And so those are some big questions. Of course, there's always research into can we come up with more effective medications for it? And actually, I'm involved right now in a study looking at some new treatments for treatment-resistant PTSD that involve a combination of medication and therapy that really hasn't been done before as a way of accelerating treatment. It's a bit controversial because it involves the drug MDMA.
Yes. We've talked to Brad at MAPS before about MDMA and some of the work MAPS is doing to try and run some trials on that.
Oh, exactly. So you've already heard about it, but
yeah.
But I'm hoping that here at the University of Connecticut, where I'm at now, we can be part of those phase 3 trials to help improve the diversity of the study, because it has been mostly white people who've been getting the treatment, and it's going to be really important to show that this treatment is effective in minority groups and people of color as well.
Monica, thank you so much for your time today. I really, really appreciate you sharing it with us today.
Oh, you're very welcome. It was great being here.
If you want to learn more about Dr. Monica Williams, her work, or PTSD, we've got some links to get you started on the show notes for this episode, which you can find, as always, on our website, which is scienceforthepeople.ca. Thanks for listening, and we'll see you next week on Science for the People. Science for the People is produced by Rochelle Saunders and edited by Ryan Bromsgrove. Helen Quivalon is our publishing liaison. We get research help from Josh Witten and consulting support from Desiree Schell. Our frequently seen guest hosts are Marion Kilgour, Anika Hazra, and Jessica Yaros. Our theme song is called Binary Consequence, and it was written and recorded by Fractal Pattern. Science for the People is entirely listener-supported. You can find us on Patreon, where you can support us with monthly donations in any amount, or you can send us a one-time donation in any amount via the donate page of our website. Science for the People is created in partnership with the Skeptic Network, a collection of blogs, podcasts, and video content focusing on the intersection of science, popular culture, politics, and social justice. You can find out more about Skeptic at skeptic.org. The show is hosted by science news writer Bethany Brookshire and me, Rochelle Saunders.